This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're so glad you're with us today. And today we want to talk about neonatal issues, birth defects, and we couldn't have a better expert than Dr. Clair Schwendeman. Dr. Schwendeman is obviously a medical doctor, but he's the Neonatal Intensive Care Unit Medical Director with Medical City Children's Hospital. Welcome to the show.
Thank you very much for having me.
You know, for many of our listeners out there, they may not realize what an important role that neonatal intensive care units do to save many of the young infants that are born in this country. What are some of the different trends that you see that are going on in neonatal intensive care units, which going forward I'll refer to as NICU? Are you seeing any trends that you can talk about?
So what we're seeing is, first I should probably state that I've been doing this since 1990, so I've seen quite a few changes over the past 30 years. But the biggest things that I see that we are doing is in the more mildly premature babies, and by mildly premature babies, I would say babies who are born 13 to 16 weeks early, so at 26 to 27 weeks of the pregnancy. We are being less aggressive with them and allowing them to do more on their own. And the reason for that is we know that whenever we happen to put them on artificial breathing support, such as putting a breathing tube in and putting them on a breathing machine, that only accelerates or increases their risk to have some ongoing lung problems when they leave the neonatal ICU. So a condition that we call bronchopulmonary dysplasia, or BPD, which is basically a reaction of the baby's lungs to being on breathing support and being used when they shouldn't be. And so a lot of our strategies now are to sort of more minimize breathing support, get the baby off of a breathing machine quicker, and allow them to breathe with still some assistance, but on their own. And that has certainly improved the baby's outcomes and decreased the need for oxygen for longer periods of time, and certainly improved their ability to go home without breathing support. Other things that we have also started to do is we realize that it's very important to, as soon as possible, get the baby's intestinal tract working. And so while in the past we may have waited for 5 to 10 days to feed the babies, we are now starting to introduce very small little feedings into the baby's intestinal tract as soon as 6 to 12 hours after life to sort of get it primed or ready to accept milk as we increase the volumes of it and switch them over from IV nutrition, which again has its own potential side effects, over to more feeding type and natural nutritional sources. And I would say the other big theme that we have done is we have tried to avoid the use of premature infant formulas. So we know that mother's milk is absolutely the best thing that we can feed these babies, that their intestinal tract tolerates it better. It also has antibodies and chemicals in it that help develop and protect the premature intestinal tract. And so what we have done now is when mother's milk is not available or there's not enough of it available, we have substituted and started using donor breast milk for these babies. And while it's not as good as mother's milk with some of the nutritional value and some of the immune protection, it certainly is much better than introducing a formula to the baby that can cause potentially severe infections of the intestinal tract that require surgery sometimes in severe cases. In other cases, at least being without feedings for 10 to 14 days. So those are some of the things that we have done probably in the last 10 to 15 years that have certainly increased the survivability of the premature babies and decreased a lot of the complications and longer side effects from being in the neonatal ICU.
You know, you talked a lot about the premature births, and some people refer to as preemies. And you talked about some of the things like mother's natural breast milk. Is there any other NICU technology that has changed, say, in the last 5 to 10 years over previous years that are helping these preemies?
Yes, we have gotten better with some of the breathing machine support that is available to us. There's a gentler approach than just the standard ventilator that we have applied to these babies in the past. One of the things that within the last 1.5 to 2 years that has been FDA approved now is a device that can be placed through a vein in the baby's leg. It's threaded up and it's placed into a blood vessel that is often a common problem in preemies called the patent ductus arteriosus, or PDA. And this is a blood vessel that's normally there while the baby is inside of mom. It connects the two major arteries that leave the body. In most term babies, it closes within the first 2 to 3 days of life and separates the two blood systems so that all the blood that's supposed to go to the body goes there. All the blood that's supposed to go to the lungs goes there. In the premature babies, especially in the very premature babies, less than 25 weeks or so, oftentimes this blood vessel doesn't close. And unfortunately, when it doesn't close, it allows too much blood to go into the lungs now, and in severe forms can actually cause congestive heart failure. We have some medications that are available to us to be able to try to close that. The success rate, especially in the very premature baby, is probably less than 50% with these medications to completely close this blood vessel. And so in the past, the only other option would be to do an operation where a pediatric heart surgeon or a pediatric surgeon would actually open the baby's chest right below the shoulder blade and go in and put a clip across this blood vessel. And as you can imagine, this is rather invasive. The babies often would have significant problems 8 to 12 hours after the surgery was done. And it also increases the risk for long-term, again, breathing complications in the future after these babies are gone home. And so now with this new device, again, we can do what's called a heart catheterization, where they basically place a long, skinny IV in the baby's leg vessel in the groin and thread that up. And then they get into this patent ductus arteriosus vessel and release a little device that basically occludes it shut and stops the flow of blood across it. And these babies tolerate this very well. Generally, it takes about an hour or two to do it. And in most cases, the babies have had very positive results in being able to decrease the amount of breathing support they're on, allowing their heart to recover. And again, a very minimal procedure.
Dr. Clair Schwendeman with Medical City Children's Hospital. You know, I have a granddaughter who was 6 weeks premature, so what a value this has been to my own family. More with Dr. Schwendeman right after this.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
We're talking about our precious kids now on the human side of healthcare with Dr. Clair Schwendeman. He is the Neonatal Intensive Care Unit Medical Director with Medical City Children's Hospital. And as I mentioned before the break, my own family was affected by this, and it was known that it would be a premature delivery in advance. So if couples are facing this, is it possible to come visit with you in person, even see the NICU? And I know we're under COVID, but is that possible before the delivery?
So yes, certainly we meet with a number of women for whatever reason when they have complications either due to multiple babies or a multiple gestation. or if they have other complications, such that the baby has been identified during the pregnancy to have some type of birth defects or congenital anomalies. Also, mothers who may be admitted due to high blood pressure or other complications of the pregnancy. So, neonatologists routinely will meet with mothers who are at high risk to deliver early and maybe have a premature baby to sort of give them an overview of what they may be able to expect. Of course, we can't provide the exact details for their babies, but we certainly can give them a bigger picture going into the hospitalization and try to decrease some of their anxiety. With COVID, unfortunately, we haven't been able to meet them in person oftentimes, and we haven't been able to do tours. Prior to COVID and what's opening up hopefully now within the next couple of weeks, at least at our facility, is that we're going to have that availability again to give the parents a tour of the NICU, which is a very intimidating place. There's a lot of sick babies there. There's a lot of alarms going off. There's a lot of bells and whistles going off. Most of them are not significant, but to a parent who's sitting at the bedside, it can be overwhelming and scary. So I would encourage that if you have been identified by your obstetrician or perinatology or MFM specialist to potentially have an early delivery or have a baby who requires NICU, to seek and be able to talk to a neonatologist prior to the delivery of that baby. If you need to be admitted, of course, we're more than happy to come up and have that discussion prior to the delivery and try to at least decrease the anxiety and, again, give you a broad picture of what might be expected while your baby's in the neonatal ICU.
You mentioned in your answer how COVID-19 had impacted some of the visitation to bring them through, show them units. Is there other factors from COVID-19 that have affected the NICU units?
Not really. In fact, quite honestly, I've been happy to say that I'm probably in one of the safest places in the hospitals, because while there have been some reports of congenital COVID, most of those babies, if it was true infection, have been asymptomatic. And so the biggest impact that I think we have seen with COVID, again, has been on the families and the parents, in the fact that if the mother was identified or the father was identified as being COVID positive and then delivered their baby, in the past there was a period of time where they couldn't visit. And they would have to see the baby either by some remote cameras or by another family member. And then at one point, visitation was limited to one parent at a time. Now things, of course, are relaxing a little bit, and during COVID, no grandparents or other family members could visit either. So the biggest impact, I think, that I have seen, at least in the neonatal ICU, is, again, just on the families and the limitations of being able to visit their baby, and also the limitations of having support services there to try to help them through this difficult time. But as far as infections and COVID and an impact on the neonatal population, I think that's been fairly minimal as far as contributing to any further illness.
You know, you see a lot of preemies, you deal with babies in the NICU. We have seen that some of the vaccine hesitancy has been with women of childbearing years and also women that are pregnant. Do you have a professional medical opinion on whether pregnant women or women of childbearing years should get vaccinated against COVID-19?
So I think they should be. I think that thus far the safety has shown to be there. And I think the benefit of probably being vaccinated to prevent a COVID infection while you are pregnant definitely has a benefit versus risk ratio. I know a lot of people are concerned because of the way the vaccine provides the protection and whether or not it may actually do something to change your DNA, RNA makeup, your genetic makeup, either in the early phase or later on in life. So I think that, again, with the present information, we have seen mothers during their pregnancy who are infected with COVID, who have been critically ill, whose baby has had to be delivered either early or emergently to attempt to allow the mother to recover. So with that in place, at this point, I don't know of any contraindications to be vaccinated. Again, it is truly a personal decision, but from a scientific standpoint, I would encourage mothers or mothers who are looking to be pregnant of the childbearing years to strongly consider being vaccinated, yes.
In your experience dealing, as you said, for a number of years with neonatal issues and birth defects, to our listeners out there, can you emphasize to them the importance of prenatal care?
Yes. So the first thing, we even carry it further than that, and that is trying to be as healthy as possible prior to becoming pregnant. So in situations where mothers are either borderline diabetics or already diabetic prior to becoming pregnant, if their control is not good as far as their glucoses, then that can also cause birth defects in the baby and or complications during the pregnancy. So I would also go back even further before you're getting pregnant to say that it's very important that if you are thinking about becoming pregnant or have a planned pregnancy, that you are taking care of yourself and any conditions you may have the best you can even prior to getting pregnant. But then into prenatal care itself, yes, I would agree that it is very important for women to get prenatal care, to be managed appropriately, to watch for the well-being of the baby. Nowadays, I would say that if the lady has adequate prenatal care, we can probably detect almost over 90% of any complications or birth defects that might be present with the baby. And we can anticipate ahead of time to deal with those. And so one of the more difficult things that we have is a baby who is delivered who might have some type of a congenital maldevelopment or abnormal development of their heart or their lungs, and we not know about it. And that situation, again, can be dealt with in the delivery room. But when we know about it, we can be prepared. We can have expectations about how the baby will respond, and the whole situation just goes much smoother. And again, ladies who develop high blood pressure or who have uncontrolled diabetes or other problems such as that, those can be managed more optimally with prenatal care and attempt to avoid a preterm delivery versus, again, a mother who might come in with a sudden condition whereby there is no choice but to deliver the baby. And lastly, the other issue that I'd like to bring up is that we have a medication called betamethasone. It is a steroid that's given to the moms prior to the delivery of the baby. And it's usually given in 2 doses, and it's a shot. And when given to the mom, we know that especially in the very early premature babies, it can make a big difference in the baby's stability after birth and in their outcomes. And so the importance of having prenatal care, whereby, again, either premature labor or some complication that pretends that the mom may need to be delivered early, if her care can be optimized with these prenatal steroids and getting the baby maybe a little in better shape to be delivered if it does need to be delivered prematurely, again, only goes in the benefit of the baby and helps the people that are providing care to that baby do it more successfully without complications and ensure a better outcome when the baby leaves the hospital.
Dr. Clair Schwendeman, the Neonatal Intensive Care Unit Director with Medical City Children's Hospital. Great insight on how we are even better saving kids' lives today. And a lot of times we get questions about a podcast. Yes, we have one. It's on all the major podcast players. So if you'd like to hear past interviews or what we've been saying lately on COVID, check out The Human Side of Healthcare on all the major podcast apps. Now, when we come back, we're going to talk about scoliosis, a disease that affects kids and adults, especially as we age. Dr. Cyrus Wong from Texas Health Harris Methodist Hospital next on the Human Side of Healthcare.
Welcome back to the Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And welcome to the Human Side of Healthcare. We're delighted that you're with us today. In today's topic, we want to talk about adult scoliosis, some of the signs, the symptoms, and the treatment. And we have a premier expert with us, Dr. Cyrus Wong, who's a neurosurgeon and spine surgeon at Texas Health Harris Methodist Hospital in Fort Worth. Dr. Wong, welcome to the show.
Thank you so much for having me on. I'm excited to speak with you today.
Well, we appreciate that. And to really help our listeners understand, can you expand a little bit on what we mean by scoliosis and what are some of the different types of scoliosis?
Sure. So scoliosis refers to an abnormal curvature of the spine to the side. So in other words, when we look at a patient from the back, their spine will be abnormally curved to the side as opposed to being straight up and down, which is how it should be. Now, that's a description of a picture or of an appearance, but there's many different categories of scoliosis related to what causes it. Generally speaking, the two most common are adolescent idiopathic and adult degenerative scoliosis. So adolescent meaning teenagers or children who are diagnosed, and idiopathic meaning no one really knows what causes it. We certainly know there's some familial factors, etc., but that's typically diagnosed in adolescence. The second type, which people are less aware of, is adult degenerative scoliosis, and that happens later on in life, typically after someone turns 50 into their 60s and 70s, and that's related to degeneration of the spine, wear and tear and breakdown of the discs, of the joints, that creates a deformity later on in life. So they're really two very distinct disease processes, and the treatment and the management is very different. There's other much more rare types of scoliosis, such as congenital or neuromuscular related to cerebral palsy. But for the most part, when we talk about scoliosis, we're talking about either adolescent idiopathic or adult degenerative scoliosis.
Are there other factors that really separate adult degenerative scoliosis from pediatric scoliosis?
The cause of the scoliosis is very different, and typically with adult scoliosis, you're going to see a lot more degeneration. Typically, you're going to see a lot more of what we call stenosis or pinched nerves related to the degeneration, disc bulges, arthritis, ligament buildup. And the spine typically is going to be much more rigid and stiff than you would see in pediatric or adolescent scoliosis, where you're really talking about what we call a flexible deformity. So that really affects the treatment and how we manage it as well as some of the other factors, such as the medical comorbidities. Typically with patients who have adult scoliosis, you have to factor that in. And then bone quality becomes an issue as well as we get later on in life. So those are all different factors that we have to take into account.
You know, and we hear about flat back deformity. What is that? What are the causes? And what problems arise from this?
Flat back deformity is another type of spinal deformity, and that's when we are looking at the patient from the side view. So what we call a lateral view. Typically, when we look on a side view of the spine, there should be a nice, gentle S-shaped curve, which results in a very nice balance between the top of the spine, which carries the head, and the bottom of the spine, which ties into the tailbone. So you have a nice S-shaped curve. And in your lower back, your lumbar spine, you have what we call lordosis, or a nice curvature at the bottom that gives you that balance. With flat back, it refers to when patients lose that normal curvature, and typically it results from the lumbar spine, the lower back, losing its normal curvature back. And as a result of that, that throws the patient forward and off balance forward. And that can cause a lot of problems, both in terms of being able to stand upright, endurance when walking, and of course back pain as well. It can be caused by degeneration from the discs losing their height from collapsing after a lot of wear and tear. It can come from fractures. It can also come from what we call iatrogenic causes, or in other words, patients who've had prior surgery, whether it's a decompression or a fusion, and where their spine may not be in ideal alignment afterwards, and that can throw things off balance as well.
You know, when it comes to adult degenerative scoliosis or flat back deformity, what are some of the treatment options, including if you perform surgery, what are the goals you're trying to achieve?
So typically when we evaluate patients with either adult scoliosis or flat back, we check on their symptoms and what is bothering them the most, whether it's back pain, whether it's leg pain, whether they have weakness, and that'll all influence the treatment algorithm. Typically speaking, we start with the least invasive measures, and that would include things like physical therapy, and that includes back strengthening exercises, posture training, gait training, things like that, working on balance. Other things would include wearing a brace. I typically don't recommend patients wear it all the time because you do want those muscles to work, but if they're really hurting or if they're on their feet for a long time, that can help. Other things could include injections that are typically done by a pain management physician. And then as a last resort, if none of these things have worked and it's been going on for a long time and they really are debilitated by this, then we talk about surgery for more definitive long-term correction.
You know, when you talk about surgery and you're looking at that long term, are there advances or upcoming changes in surgery on the horizon?
Yes, absolutely. So the way we manage and the way we correct spinal deformities like scoliosis or flat back are really has really advanced in leaps and bounds, and a lot of it comes down to the technology that's available to us these days. So I always say, 10 or 20 years ago, if you went on a road trip, you'd have to get out your Rand McNally and plan out a chart and all that. Nowadays, we all have GPS and it's on our phone, and it's so much easier, more accurate, more convenient, and faster to do it. Very similar as far as surgery goes. So the instrumentation we use these days, we typically will use what we call pedicle screws, or titanium screws that are placed in the bone, and they're connected by rods, which allow us really powerful measures to correct the deformity. These screws are typically inserted these days with a lot of help from technology like what we call stereotactic navigation, very similar technology as your GPS machine that allows for a lot of accuracy. Other things that we do as far as the planning and being able to be very precise in how we correct these deformities and plan for optimal balance, we can use software programs beforehand. We can use predictive planning as far as that goes. And that really allows us to get a much more precise result than, say, 10 or 20 years ago when people were correcting these deformities.
You know, if you have a patient that has adult degenerative scoliosis and you're planning that surgery, how does that differ than when you're planning surgery if someone has more routine spine problems?
Absolutely. So that's a very good point, and that may be one of the most important take-home points is that if you do have significant adult degenerative scoliosis, it does affect, even if you were to have a routine surgery, a routine fusion or things like that, it should be taken into account. And what I mean by that is, for example, if someone is undergoing a spinal fusion, it's important to know how the curvature of the spine might affect that. And what you don't want to do, for example, is to do a fusion at a couple levels right below the apex of a curve, so right below the highest point of a curve. And that can kind of set things up for breakdown down the line. So there's various planning that goes into account when someone has significant scoliosis, and that includes taking full-length x-rays of the entire spine in order to plan and make sure we get the optimal result. Generally speaking, the goals of surgery, of spine surgery, are number one, decompression, getting pressure off the spinal nerves, and number two, stabilizing the spine when there's a lot of breakdown to help with back pain. With scoliosis, we also have to factor in the overall balance of the patient so that when they stand upright, they'll be well balanced and be able to get about their daily activities without issues.
Dr. Wong, many children don't have scoliosis, but as they grow older and we all begin to age, is it possible that as an adult you develop scoliosis even though you didn't have it as a child?
Yes, that's exactly it. And I think the take-home point is that scoliosis really refers to an appearance. What causes it can be very different, and adult degenerative scoliosis or will come on later on in life and is not related to adolescent scoliosis typically. And it's really related to breakdown, degeneration, and wear and tear, and what we call the degenerative cascade. So in other words, if you look at a stack of Jenga blocks, all it takes is one little off-balance block to start throwing everything else off. So when someone starts to develop wear and tear and breakdown of their discs and joints, and it starts to throw off their balance a bit, that will increase the stress on the other levels, and over time that can continue to progress and result in this deformity. It's a slow process. It's like a Jenga block falling over in slow motion, but that's the general idea behind it, and it does happen later on in life.
You know, as you're talking to our listeners, if they feel that maybe they're developing adult scoliosis, what would you say would be your takeaway message to them?
Sure. So the first thing to know is some of the signs and symptoms that we've talked about before, which includes, for example, tilting to one side, whether it's the shoulders or the hips, feeling off balance. Other things like what we call sciatica or shooting pain down the legs, which could be related to pinched nerves, back pain as well. And that's something that they should bring up with their primary care physician first, and they can start with things like getting some x-rays, which can confirm whether or not they have scoliosis. And then the next thing to know is that there are things that can be done to help with this, ranging from starting off with physical therapy, conservative options, and then all the way down to more definitive correction of the deformity. So it's not something they necessarily need to just live with or suffer through, or that it's just an inevitable part of growing older. There are very effective treatments, whether it's non-surgery or surgery, that can significantly improve the patient's quality of life.
This is Dr. Cyrus Wong. He's over at Texas Health Harris Methodist Hospital talking about a disease that affects kids and adults as we age. When we come back, the role that sitting all day plays in developing back problems. Next on the human side of healthcare.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
And we're glad you're back. We're continuing our conversation with Dr. Cyrus Wong. He's a neurosurgeon and spine surgeon over at Texas Health Harris Methodist Hospital. We're talking about scoliosis, a disease that affects kids and adults. But for adults, I think you and I have the same question in mind. So the floor is yours.
Dr. Wong, in adult scoliosis, is it more prominent in males or females or equal?
I see it pretty evenly, actually. And the interesting thing is we don't know exactly the prevalence because it's very hard to know for sure, but some estimates put it as high as 60% for patients above the age of 60. So it's definitely very age-related, but not necessarily predominant within men versus women.
You know, you've given us a wealth of information and you've explained it so well for our listeners. What questions should I have asked you that I didn't?
One of the things I'd like to mention about adult scoliosis is, again, a lot of the advancements in technology that allow us to do surgery a lot more precisely, a lot safer, and as well as a lot of the advancements in the OR that allow us to perform these surgeries safely in patients who are typically older. And that includes having a great anesthesia team. That includes certain technologies that we have these days where we can actually recycle blood loss during the surgery back to the patient to decrease the need for blood transfusions, as well as the ICU team afterwards that takes care of the patient typically for the first day or so, and the rehabilitation process as well. I always tell my patients if we do end up doing deformity surgery, we have a very good potential for improving their quality of life significantly, but it's a process, and there's going to be a rehabilitation process afterwards, and we're going to participate in physical therapy, and there's all these different team members that play a part in helping the patient recover afterwards.
Dr. Wong, is our lifestyle contributing to this as far as we sit all day?
Yes, I think that's a big part of it. That's a great point. Sitting for a long period of time typically will put a lot of stress on the lumbar discs and on the lumbar spine. And I always advise my patients, if you have an office job, if you have a desk job, take some breaks, stand up, walk around, maybe even use a standing desk for a bit. That certainly plays a big part of it. Weight obviously also plays a part into it, given that the spine essentially holds up the body weight, the more weight there is, the more wear and tear, especially at the lower spine, where the lumbar spine, where it holds the majority of the weight. I always encourage good ergonomics, lifting, using your legs, not rounding your back. A lot of that will add up over time. It's not so much something that happens overnight, but it's a lot of wear and tear that accumulates over the years.
So what's the distinction between somebody that has a disc fusion and the potential of scoliosis developing later on?
Typically, with a fusion, they won't necessarily develop scoliosis afterwards, but they can develop degeneration on the adjacent levels. So in other words, afterwards, there can be continued degeneration and wear and tear of whether it's the disc above or below. Now, it's a bit of a chicken and the egg situation where certainly it might be partly related to some of the stresses from having a fusion, but it can also be, for example, when they've looked at studies where patients just have a laminectomy or decompression, they also have similar rates of adjacent segment disease. And a lot of it comes down to, again, that degenerative cascade, where once one area starts breaking down, a lot of that stress gets transferred to the next levels, and that kind of accelerates the degeneration process there.
So what happens, I guess, is when somebody blows L4 and L5, that's isolated. If they get scoliosis, that's more general?
Yes. So an L4 or L5 herniated disc is going to be a focal one level, what we say one level or one spine segment problem. Whereas when we're talking about scoliosis, we're really talking about a global problem. So the global spine picture. And that's really related to the overall curvature of the spine when we're looking at a patient from the back.
I know we've all seen folks, men and women, I think equally, who approaching their 60s and 70s might start to slump their shoulders and get a little bit of hump in the upper part of their back.
Yes.
Is that pre-scoliosis?
That is more related to flat back deformity, and that's when we're looking at a patient from the side. And it's a result of mostly a result of losing that lordosis in the lumbar spine. In other words, that nice gentle S shape that keeps them in balance. And that's typically because the discs, which act as shock absorbers over time with the wear and tear, they begin to lose their height and lose their elasticity, in some cases even becoming bone on bone. And you multiply that over multiple levels, and you end up with a lumbar spine that's very flat like a board, and that throws everything forward. And that's when people can have a lot of problems standing up straight, and they can also have a lot of back pain, have a lot of problems with their balance or walking endurance. And I think the take-home message on that is that we don't necessarily do deformity correction surgery on all of these patients, but when it's severe, there are options to correct it and really restore a patient's balance and alignment to where they're standing up straighter, and that can make a very big difference in their quality of life.
So then catching it early is a really big deal in your world then.
That is important, and it's one of those things where we don't necessarily operate on every single case, but it is good to know, and it's also good to be able to track it, say, is it getting worse over time, and have a baseline to compare with.
So for our listeners who are in their 40s, 50s, 60s, even 70s, and they don't feel like they have it yet, but they don't want it, top 3 preventive techniques.
So number one would be aware of your general ergonomics on a day-to-day basis, your posture, how you're sitting, how long you're sitting, etc. The number 2 would be preventing wear and tear on the spine, and that can be things that are going to be high-impact twisting, rounding your back, bending over, picking things up off the ground. All those things will add up over time, and really paying attention to that early on will pay off over the long term. And then the last thing is weight plays a big part into it, and if there are already some back pain issues and things like that, one of the most effective things that someone can do is to, for example, weight loss and things like that to decrease the stress on the spine.
That's amazing. Great advice. Now, I have one of those inversion tables.
Mm-hmm.
What are your thoughts on those?
I think if those are helpful, then I would certainly encourage you to use that. My general advice to patients is there's a whole host of options as far as conservative or non-invasive treatments. Some patients find good results with them. Some patients don't feel like they make any difference. My general rule of thumb is that if it doesn't hurt you, it doesn't cost you a lot of money, and you feel like it helps, then go ahead and do that. But inversion tables, a lot of patients do feel like it takes some stress off their spine and helps them decompress, and that's something that's been used quite a bit.
Dr. Cyrus Wong, he's a neurosurgeon with Texas Health Harris Methodist Hospital. Thank you so much for enlightening us on scoliosis. Steve?
What a great guest. I learned a lot about scoliosis, and I learned a lot about NICU today. What a great show, Thomas.
It was, but we need to keep looking forward. And Steve, if you look around, there's a big elephant in the room that I'm afraid most people don't yet see.
No question about it. And the elephant's getting bigger. And we all know it's COVID-19. And you know, Thomas, I know people are completely worn out, but this Delta variant is nothing to fool around with. It's very contagious. Majority of the people in the hospital have not been vaccinated. You've heard even from some professional groups, the pediatrics, we need to wear a mask. We need to use every tool in the toolbox against this ferocious virus.
Yes, and what I'm seeing out there is life is pretty much normal. So it seems to me like we haven't had a big enough wake-up call. So what does the near midterm future look like?
I really think what's ahead as school opens, and many of the kids may not themselves show severe symptoms of COVID or the Delta variant, but they may bring it home, and if 50% of the adults they come in contact with have not been vaccinated, we're going to have a spread. And Thomas, the thing people tend to forget, the more times it replicates the virus, you have more chance of mutations. And sooner or later, unfortunately, we might get a mutation that is completely resistant to the vaccines.
On a scale of 1 to 10, 10 being extreme, how bad is it right now?
I would put it at about a 4, but I think as we approach the cooler weather, school opening, by September, October, we could be at a 6. So to our listeners out there, if you haven't been vaccinated, please read the facts, talk to a trusted colleague, and please get vaccinated. And if you're in a large crowd, continue to wear a mask. Thanks for listening. Look forward to seeing you next week.